Okay, so I'm going to go ahead and get started. Today, we're going to talk all things IVF. The idea of this talk is just to give everyone here a deeper understanding about the processes of IVF. And so this is me, Dr. Toral Parikh. I am one of the Kindbody Reproductive Endocrinologists. I provide care to the Houston area and also cover a bit of Washington, D.C. Our mission at Kindbody is largely to widen access to infertility treatments as well as fertility care using state-of-the-art technology. And our goal is to fight for our patients when it comes to benefits and providing them access to the treatment that they may need in order to obtain the goal of having their family. We do many things under our umbrella. We offer a variety of fertility care, whether that be for the single individual, same-sex couples, our couples who may have already had a child and are having difficulty trying for their second. And so the goal here is to offer options available to all patients. In addition to that, we do provide some counseling and support. We want to make sure that our patients are both physically, mentally, and emotionally ready to undergo the process. And that is important when undergoing treatment. It's really important for us to understand that this is our journey just as much as yours. And so your ups are our ups and your downs are our downs. And so the biggest factor that we feel that is important is time to treatment. It's really hard to be able to make sure that we're performing our treatment plans within a timely manner. And so it's our goal to try to make sure that your care is one that is succinct and getting to your goal of having a baby as soon as you are ready. So just to break down the process of fertility and trying to have a child, everyone here, is probably aware an egg, a sperm, and a uterus, as well as plus or minus tubes, depending upon the process in which we conceive, are necessary in order to make a baby. And so when talking about eggs in specific, as women, we are born with the total number of eggs that we will have for the rest of our lives. The understanding is that this is somewhere between 300 and 400,000 eggs per individual, and that roughly every month we lose about 1,000 of these eggs. Not all of these eggs will be able to make it to the point at which they'll be stimulated to turn into that one dominant egg that we typically make per month. Occasionally, women make 2 eggs a month and potentially can have a chance of having twins, but generally speaking, on average, most women create 1 egg a month, if that. And so in order to test the number of eggs that may be available for an individual, we perform basic workup or blood work as well as ultrasound testing to get an understanding of a woman's ovarian reserve. So you may have heard, what is your ovarian reserve, or how many eggs do you have on your ovaries? What we usually do is do hormone testing to figure out where the hormones from the brain and the ovaries are set at and what your levels are, and then compare these hormone levels to what we're seeing on ultrasound. And occasionally, blood work may not always reflect an individual's ovarian reserve, and occasionally the ultrasound may not reflect the individual's ovarian reserve. There could sometimes be a big cyst on the ovary that may kind of make it hard or mask the abilities to see the follicles in one's ovary. And sometimes different variety of things such as birth control or other medications or disease processes, disorders may affect one's AMH level. So we use a combination of these two things to get an understanding of where an individual's ovarian reserve is at. And then we use that information to help counsel patients in terms of how many eggs we expect to retrieve should they undergo the process of IVF. Now, this doesn't reflect the individual's ability to conceive. Some individuals have great ovarian quality, or egg quality is what we refer to it as, and that egg quality may require just a few eggs that are needed in order to get the number of embryos desired. Others may not have as great egg quality, and so may require more eggs in order to get the number of embryos they desire. So it really just is an independent reflection on each individual. And so here you can see a ultrasound image of an ovary. Each one of those little bubbles inside the ovaries, or we liken them to champagne bubbles, sort of fizzle up to the outside of the ovary and contain an egg inside of it. And so, as you can imagine, recruiting these eggs every month, your ovary then selects one particular follicle or egg to then help to push to become the dominant egg for that cycle. With IVF, we try to basically take over the process by which this signaling occurs for that one egg to develop and really try to sort of stimulate all of the eggs that are here seen on the ultrasound to become dominant eggs so that they could be retrieved and an individual's eggs can be then preserved or embryos could be then created via IVF. So just the general concept here, the ovary sort of sits right next to the tube. It is not attached to it by any means. The tube sort of waves and brushes the ovary as the body moves or as the individual moves. That tube will brush the ovary and pick up an egg. The egg will then travel into the tube and hold itself there for roughly 24 to 48 hours, whereby certain timing of intercourse will allow sperm to actually travel up from the uterus, from the cervix into the uterus and through the tube, where the sperm and the egg will meet within the tube. The egg actually fertilizes within the tube, and then over the span of 3 to 5 days, that embryo then that develops will then roll itself on its way back into the uterus and implant inside the uterus. When this process doesn't occur appropriately, we find patients have difficulty conceiving, whether that means that the egg can't actually meet the sperm or that the embryo that's early on doesn't roll appropriately into the uterus to implant. And so finding out where the problem is occurring is important. And so we do a variety of tests to try to find out where the problem is occurring. So a lot of times individuals will ask me, what's the timeline? Why 35? Am I 35 and am I just going to lose all of my eggs? It's not the case. The number 35 was largely based upon studies that were being done in women over 35 and younger than 35, and that's where the number has occurred. But for every individual, this number at which point the egg quality sort of declines and then subsequently the quantity of eggs available declines differs. For some, that may be 30, 32, 35, or even 38 or 40. And so oftentimes, depending upon a patient's ovarian reserve, we can find out, generally speaking, where they may actually fall on that curve. But then with IVF, we may be able to then figure out the actual quality of those eggs. Prior to actually fertilizing the eggs and seeing how they then subsequently develop into embryos, we don't actually have a test available to inform us of the egg quality to date. There are a variety of tests that are out there that currently may give us an understanding of whether an egg is a good egg or not, but at this point, all of that is still quite experimental, and so we really have just IVF itself and the embryo development to judge the egg by. 1 out of 10 women will experience this decline earlier than the age of 35, and we call that premature ovarian failure or diminished ovarian reserve. These might be terms that you may or may not have heard or are been exposed to, but this is a finding that's concerning and that often leads to difficulties conceiving later on. And so the goal of our company and our providers is to ensure that patients have access to education to know that they can test this reserve, and then subsequently provide them with an avenue to talk about options that are available. And so speaking then to egg quality, the older we get is whereby which we judge that quality, aside from how the egg actually then develops with the IVF process. So an individual who's 30 is thought to have better egg quality than somebody who may be 38, but that may or may not always be the situation. With age, aneuploidy or abnormal DNA will increase, and so the ability and chances of having a baby then subsequently declines accordingly. We know that 1 in every 3 individuals or pregnant individuals will end up in a miscarriage, and that's due to largely this aneuploidy or abnormal chromosome or genetics of this embryo that can occur. And so as we age, that 30% likelihood of aneuploidy increases and the chances of an actual live birth decreases. Talking about ovulatory dysfunction, there are many reasons why for individuals that egg may not actually leave the ovary. And so the chance of an egg and a sperm actually meeting are low. Individuals with PCOS or polycystic ovarian syndrome, these individuals, I liken it to a traffic jam, have so many eggs that the signal to have one of those eggs push through and become the dominant follicle doesn't always get relayed. And so in these individuals, getting them to the point where ovulation occurs is really important because their chances of conceiving are a lot higher once they do ovulate regularly. Individuals with thyroid prolactin dysfunction can often find themselves almost with a resistance to ovulation. Low thyroid levels or extremely high thyroid levels can impact the signaling for the ovary to then create that dominant follicle or egg for the month. Hypo is hypothalamic hypogonadism. It is a condition in which the brain is just not giving enough of a signal for the ovaries to do their job. And so because the stimulation doesn't come from the pituitary, the ovaries don't know how to function. And so that signal is really important. And we have ways to help assist individuals with this condition to help them ovulate and get that stimulation so that they may ovulate regularly and be able to conceive more successfully. And lastly, ovarian failure, which I just kind of just touched upon earlier, which is whereby which the follicle counts actually decline earlier than age 35, maybe at age 25 or 30. And so the individuals face a more difficult time conceiving when they are ready to conceive at an older age. Talking about the tubes, there are things and treatment plans within the realm of infertility that we use where we do need the tube to actually be open and functioning. When patients are undergoing treatment plans such as medicated timed intercourse or natural cycle intercourse, we do confirm that the tubes are open and with good flow for the sperm to then meet the egg. Roughly 5% of individuals with the studies to help show tubal opening or fallopian tube patency can actually lead to conceiving. And so I liken this situation as for HSGs and bubble studies to Drano. And so we kind of sort of shoot some dye within the actual cervix. It goes into the cavity, spills out the tube, and sort of helps to push any mucus plugs and ensure that the tubes are actually open and that our attempts to help the individual or individuals conceive are as high as possible. Talking about the ovarian cycle, you can see that the growth of the follicle starts with a primordial egg, and then that subsequently grows into what we say a mature egg. That mature egg will then ovulate off, leaving behind sort of like this empty sac, which then forms what we call the corpus luteum. That corpus luteum forms or secretes progesterone, which helps to keep the lining nice and thick and intact, so as to allow the egg and the sperm to meet and then subsequently create an embryo and implant into this very nice blood filled and rich lining to implant in. With IVF, we basically take over this entire cycle, whereby which once the egg actually is mature, we actually then subsequently aspirate it using a needle vaginally and remove the egg from the ovaries. And then the subsequent process that occurs here on the latter half is then simulated using injectable medications. So individuals with tubal dysfunction will have blockages in their tubes or slash a thickening of their entire tube that will prevent them from allowing the egg and the sperm to meet normally. And so in these individuals, IVF can be a process whereby we bypass the tubes, and your physician may recommend removal of the tube prior to this process just to improve the chances of implantation occurring. In order to evaluate this, I mentioned earlier, we can use either an HSG or a saline sauna or bubble study, which is where we place some bubbles inside the uterus without using radiation and see that the tubes are open and flowing. The uterine lining is really important when it comes to implantation of an embryo. We will do ultrasounds to check the thickness of this lining, which is very important. Studies have shown that the pregnancy rate dramatically improves with each millimeter increment of thickness within the lining. And so we use medications to help thicken the lining to improve the chances of implantation, especially in women who may not have a very thick lining to begin with. Using these medicated or prepped cycles may actually improve an individual's ability to conceive. We look for something called a trilaminar appearance. So you can see this nice white line in between these bright thickened areas on the side, and that appearance allows us to tell us that the lining is ready and is mature. Now, once progesterone is exposed, that line in the middle, that trilaminar appearance goes away, and you can see it more of a milky appearance to the lining, and that's evidence of progesterone being on board and implantation being ready to occur at that point. Evaluating the uterus, we do both just general ultrasounds transvaginally as well as saline ultrasounds to understand and make sure and ensure the cavity of the uterus is nice and open. I always tell patients that the inside of the uterus is kind of like real estate. Any small little polyp or fibroid that may be inside the uterus may actually impact the location and ability for a embryo to implant. And so this study is very important prior to any treatment procedure, whether that be IVF or non-IVF methods, just to ensure that we're maximizing the ability of an embryo to actually stick on the inside of the uterus. So testing that we would do again here would be a saline ultrasound, and we're looking for these abnormalities. We typically tell patients to come in with ibuprofen on board an hour prior to the procedure, as cramping can occur as the fluid goes inside the cavity and becomes a bit distended. And so some patients really feel nothing, and others do feel some discomfort associated with the procedure. Really, when we're doing this process, we're looking for abnormalities also in the actual uterine cavity or shape of the uterus. When they're abnormal septations or adhesions or slash actual structure overall of the uterus, this can lead to decreased pregnancy rates and issues with recurrent pregnancy loss. And so this is the process by which we're just basically working up the individual to ensure that these things don't occur. And if they are present, to maximize the ability for that individual to conceive by either repairing those issues or to plan their treatment plan accordingly to improve their outcomes. Flipping to the sperm. So we've talked about the egg, we've talked about the uterus, now we talk about the sperm. These are the three components. There are a wide variety of sperm shapes, sizes, motility, and morphology that we always see. Morphology is one thing where we don't know the true impact on whether or not a sperm shape affects the ability for fertilization of an egg, but the general understanding is that a normal shaped sperm would be better able to fertilize than an abnormally shaped sperm. So for example, a sperm with a normal head would be better than a sperm with two heads or two tails. What happens naturally is quite unknown. But from the perspective of IVF, we always strive to pick up this normal sperm to help improve the ability for an egg to actually be fertilized by a sperm. And so generally speaking, the process of making sperm usually takes roughly about 90 days. We look for other qualities that are also important. The primary quality being, or the primary parameter being an individual's concentration. And so how many sperm per ml does an individual have? And we look for a value greater than 15 million. We also are looking for motility because non-mobile sperm is not going to lead to an increased chance of conception given the fact that the sperm just don't move. And so motility, we look for greater than 40%. The morphology is a soft parameter. Individuals who have normal other parameters and just a morphology that may be off, they may or may not deal with difficulties conceiving based on their morphology. And so this is something that can be affected by an individual's lifestyle, exercising, diet habits. And so we try to use these lifestyle changes to help improve the morphology as well as supplements to help improve an individual's morphology if we can. Other factors that are not necessarily always reported as easily, but are commented on when doing a semen analysis is the individual's volume, as well as thickness of their fluid or viscosity and how sticky the sperm is. And this kind of sort of helps us to gauge how good the semen analysis specimen is. When looking at male reproductive health at Kindbody, we offer a variety of tests available to help ensure that we're also maximizing the sperm, since it is the second half of what we need to create an embryo. We have testing parameters such as DNA fragmentation, CAP scores, testing of hormones for men, as well as infectious diseases, and ultrasounds to ensure that they don't have varicoceles or things that may help to prevent their counts from being normal. And so by fixing or repairing these things, we may end up with better outcomes. And so we're always striving to ensure that the sperm parameters are optimized in addition to the eggs being optimized, or the female individual being optimized for good outcomes. Turning now to testing, we do require that individuals undergoing treatment at Kindbody have good medical standing. And so to ensure that, we require that individuals have and be up to date on their pap smears, as well as have a recent breast exam done. If you're over the age of 40, we require mammograms to be completed. And if you're over the age of 45, we do recommend or require just a general physical evaluation from your general practitioner or a maternal fetal medicine individual, just to ensure that you're in good health standing prior to undergoing treatment. And that's just to ensure that we're safely intervening and helping you in your journey to conceive. Hormones that we test for are thyroid and prolactin. These hormones can often change with age, and so we're always testing these hormones to ensure that they're ideal. Infectious disease testing is just to ensure that there's safety between partners when undergoing fertility care. Genetic carrier screening is something that we offer to help prevent disorders from being passed on generation to generation. You may not be aware of what mom and dad has passed on to you. And so when two individuals meet and then subsequently create progeny, since we are doing interventions that can have genetic testing performed, we screen our individuals prior to undergoing testing or have them sign a waiver if they're declining that testing. And always, we always make sure that vaccinations are up to date and that there's minimal risk to both the mom and the baby once conception occurs. So going a little bit more, delving further into genetic screening. This is something that we do by blood or by saliva. Typically, we try to do it by blood as it has better outcomes. And we're looking for what we call recessive conditions, whereby you carry a gene for it, but do not actually have the disease process. And in testing for carrier status, roughly 25% of individuals who both carry a particular mutation, roughly 25% of their progeny would then be affected by that mutation, and that is what we aim to prevent. Other factors to consider while undergoing treatment is what an individual's actual BMI or weight, as weight has a direct impact on an individual's ability to have good ovarian reserve, as estrogen inhibits the ability for follicles to be stimulated. And then also as it reduces the ability to conceive when an individual's weight is on the higher end for their body size. And so these are things that we try to counsel on prior to undergoing treatment. In addition to Zika, as well as COVID, we want to make sure that the patients that are undergoing treatment are under good care and good health. And then supplements. Supplements is a whole another lecture that I could probably give. There are a variety of supplements that are on the market to help improve sperm parameters and egg parameters and try to boost an individual's ovarian reserve. And so there is, a continuous slew of research that's always done to kind of sort of help to push certain things as opposed to others. And so in your individual sessions, we can talk about what supplements are recommended. Every provider will be a little bit different on these supplements. And so it is something that there is not a clear-cut understanding. We do know that prenatal vitamins is a must. And so, having folic acid on board when attempting to conceive or even preserving one's fertility is known to be definitely affecting ovarian reserve and quality. And then your provider and you, and if that happens to be me, we'll discuss what supplements we feel is best for you to be on. So let's talk a little bit about what your goals are. Short-term goals are always, how soon do you want to get pregnant? Or are you just preserving your future fertility? Long-term strategies always include how many children do you want? Are you looking for 1, 2, 3, or more? And so generally speaking, our treatment plans are usually created having that end goal in mind. For women, age is always an issue for their fertility. As they grow older, the egg quality declines and then the egg quantity declines. And so to preserve one's fertility younger and earlier is always best, and what we strive to do without having to be too invasive in the process, and to also allow for natural conception to occur should one be able to conceive naturally with just a little assistance from us. IUI versus IVF may impact the individual's ability to conceive later. For example, an individual who's already struggling to conceive, undergoing the process of multiple IUIs, and then finally conceiving may find themselves in a much more difficult situation when they're ready to have another baby. And so IVF may provide an avenue through which we may be able to get them pregnant to their first child and then subsequently bank embryos for subsequent children that are desired. What does it actually mean to be infertile? The definition of infertility, by definition versus what fertility providers use is a little variable. But generally speaking, if you're younger than 35, we say a year of trying with unprotected intercourse. And then over 35 is 6 months of trying with unprotected intercourse, with the understanding that roughly 1 in 8 couples will experience some form of infertility, and a third of that will be male factor. Nowadays, most research is even showing a higher, percentage of male factor fertility, closer to maybe 50%. So IVF, what is it and how does it work? What we do is we just take those eggs that have been recruited for your cycle for that month, and we stimulate them and retrieve them before they ovulate, and then subsequently either preserve them in their state as eggs, or subsequently perform ICSI or traditional fertilization, whereby we create embryos. During this time, you would be on injections, which are given to help stimulate the eggs and take over the brain ovary process for roughly about 10 to 12 days. And then after that, a trigger shot is typically given, and the eggs are matured prior to removing them or retrieving them. How do the injections work? It's fairly simple. There are instructional videos that we always give for you to pause, repeat, play as you need according to your understanding of the medications and at your pace. And the idea here is to make sure that you're as comfortable as possible with the medications and allow you to take those medications in the comfort of your own home without having to come to the clinic every single day for us to administer those medications for you, as that can be burdensome on your schedule. So this is just a little video going over.
Hi, my name is Hina. I'm the patient navigator.
And Hina here is kind of going over the medications, and you can see her pull out the medications from the box. She kind of shows each one of the medications, the labels, what things to look out for. And it's just a really nice, simple way. It's a very short video from the standpoint of video length. And so it's an easy video to watch. And once you've done this 2 or 3 times in a row, most patients get the gist of it and are ready to kind of teach other patients how to do the process. And so it does take some training, but once you've got it down, it's pretty straightforward. MedTeach is a session that we have available through our Kindbody website that patients can go on, and every week we have live sessions where individuals can learn the process of having medications administered, so that prior to preparation of starting medications, they feel more comfortable injecting themselves with help or without help if it is available. How does the egg retrieval process actually work? It's fairly quick. Once we've monitored you throughout the process of the stimulation, you would be coming in for ultrasound and blood work roughly every other day. Once we've determined that your eggs are at the point at which they are ready to be retrieved, you will be asked to come in at a certain time and a date, depending upon when your trigger shot was given, and prepped for the retrieval process, by which you'll be placed into a gown. An IV will be placed. We do give light anesthesia using propofol. There is a licensed anesthesiologist available, or CRNA available, to administer that anesthesia, and who will be monitoring you throughout the entire procedure. Most egg retrievals roughly last somewhere between 10 and 20 minutes, depending upon the number of eggs that are planning on being retrieved. A larger egg count may require more time to retrieve the eggs, and care is always taken to try to get the maximum number of eggs retrieved that will lead to maturity and subsequent preservation or embryo development. On average, we tend to get somewhere between 10 and 15 eggs, sometimes more, sometimes less, and that's where we use your AMH and your specific AFC or antral follicle count level to determine how many eggs we are predicting that you will have. After that, once the egg retrieval is completed, there is an embryologist who's actively on the other side of our retrieval room, sifting through the fluid that they've been given and looking for your eggs. We expect that roughly 80% of the eggs we saw on ultrasound are actually retrieved, and roughly 70% of the retrieved eggs that are mature will then subsequently fertilize once the ICSI process or insemination of the egg with the sperm has been performed. Following fertilization, the embryos are followed for roughly 5 to 7 days, depending upon the embryo's development. And during this time, we try to allow the embryos to do their job in the incubators, not trying to disturb them. And so you will typically hear from us in terms of your outcomes on day 7, where we inform you of the number of embryos that made it to what we call the blastocyst stage, or the final embryonic stage prior to being frozen. At this time, this is when embryo biopsies are usually performed, and roughly we expect that 50% of the embryos actually developed into a blastocyst stage. Once the biopsies have been performed, the embryo is then frozen, and we await the testing of those biopsies to determine which embryos are of normal genetics and suitable for transfer. Only embryos that are suitable for transfer are frozen. So we try to do our best to freeze high quality embryos so that an individual has the highest chance of conceiving with their embryos. A lot of times patients will ask, how do I know if my embryos are healthy? Grade of embryos is based on appearance as well as PGT testing, and we use the combination of these studies to determine which embryo to actually transfer, depending upon the embryo grading as well as the euploid or PGTA status. That will determine the percent success rate associated with each embryo you have. Roughly, PGT is not always perfect. It is also fraught with issues. Generally speaking, we would like to, studies have shown that 90% of the times it is accurate, and that it helps to prevent the transfer of embryos that may not be yielding high pregnancy outcomes, as well as embryos that may lead to pregnancy loss and subsequent pregnancy failure. Who is PGT recommended for? There are all forms of patients that PGT can be used for. The typical patient is it's used for individuals who are of older age and are looking to kind of ensure that their miscarriage rates are minimized. And so we try to ensure that we have a euploid embryo available for transfer. In addition, for patients who have had issues with miscarriages from prior, we typically test the embryos prior to transfer, and so this is a way that we minimize recurrent pregnancy loss. Individuals who are found to be positive for carrier testing and with both partners or one partner with the disease process that could potentially affect a future child, these individuals would then also use a different form or a combined form of PGT to help improve their outcomes and ensure reduced transmission of those situations to their progeny. Moving forward, the benefits of PGT allows us to ensure that there are actually an equal number of chromosomes and that they are balanced. We can also determine the sex of the embryo for individuals looking to family balance in the future, maybe, as well as increase the chance of a successful pregnancy by reducing the miscarriage rates for an individual. Individuals who choose not to do PGT, there are also a variety of reasons. The actual process of PGT is not perfect. It is also an added expense. And so in order to curb the expense, individuals may decide not to test their embryos. It does reduce the embryos available to transfer. And so individuals who may be concerned that they may not have an embryo to transfer or would like to allow nature to decide whether the embryo is suitable for pregnancy may consider not to do PGT. Generally speaking, my younger patients, I will counsel them that PGT is not necessarily needed, that it can be done to help ensure or help to select the embryo that is desired for transfer, but it's not mandated or advised. I always like to make sure that patients understand the general decline in the number of eggs that are retrieved. This is a great way for patients to understand just expectations of what to see in a typical IVF cycle. So for example, for an individual who may have 12 follicles that are being monitored by ultrasound, so those are 12 eggs that we're looking at and measuring in sizes. When we actually do the retrieval, we may get 12 of those follicles, or maybe I usually will say 80% less, so somewhere between 10 and 12 of those follicles. And then roughly about 80% of those will be mature. So you can imagine 10 mature eggs. Roughly 70 to 80% will fertilize, so somewhere between 7 to 8 fertilized eggs or embryos. And those will then subsequently grow, and we'll see again a roughly 50% decline from there, whereas to have somewhere between 0 to 4 normal embryos by PGTA that are tested that then can result in a baby. On average, roughly 3 euploid embryos will lead to a 95% success rate for one child, and somewhere roughly around 40 to 50% chance for a second child from those 3 embryos. And so just to give an idea of how many embryos should I bank for the 2 kids or the 3 kids I want, that's generally what we counsel patients for. There are different types of embryo transfers. You could either have a fresh embryo transfer or frozen. The general gestalt is now frozen embryo transfers are a bit higher in success rates than fresh embryo transfers, but this all depends on the type of cycle that you are undergoing. If you have eggs that are frozen and that you are then subsequently fertilizing and considering for transfer, some individuals believe that in that setting that maybe a fresh transfer may be actually better than a frozen transfer, as the body's not undergoing the process of being exposed to high level hormones that could potentially reduce the chance of a pregnancy outcome. Embryos have roughly a 95 to 98% chance of surviving the thaw process, and so they do pretty well, whereas eggs usually have somewhere around an 80% survival rate, and so a bit lower because we're looking at only one cell. Why is an FET recommended? It's largely because generally with IVF, the hormone levels are somewhere, estrogen levels can be somewhere around 2,000, 3,000, 4,000. And so during a typical embryo or pregnancy cycle, since there's usually only one egg, the estrogen levels are somewhere around 200 to 300. And so since the hormone levels are 10 times their normal, we usually like to wait for the hormone levels to fall to a more natural level, and then subsequently prep the lining or use a natural cycle to create that more normal environment for a pregnancy to occur. This is just a typical calendar for frozen embryo transfer. So an individual will come in with their menstrual cycle. They'll be put on estrogen for roughly about 2 to 3 weeks, at which point their uterus will be monitored to ensure that it is having the appropriate thickness and trilaminar appearance that I had mentioned before. And then progesterone shots will be started, and that goes on for roughly about 6 days, and on the 6th day, an embryo transfer is usually performed, following which you'll continue all the medications, and then 9 days later, the pregnancy test is done to see whether or not you've conceived from the frozen embryo transfer, putting this individual at 4 weeks pregnant from day 1 to transfer an outcome of pregnancy. The embryo transfer is performed using a thin catheter that's sifted through the uterus. Your provider will decide whether a mock transfer needs to be performed prior to the actual set of an embryo transfer. The procedure itself is roughly about 10 to 15 minutes from start to finish. We bring you into a room, an ultrasonographer will then show an image of your uterus live, and we will watch the catheter move in to the certain point at which we think the embryo transfer should occur. The embryologist usually brings in the embryo once we're at a location that's suitable for transfer, and the transfer then is performed, and the individual usually stays on the bed for roughly about 5 to 10 minutes max. Sometimes just gets up right away, depending upon the location and the culture of transfer at that location. And then subsequently, the individual will go home and rest and relax, not having too much exertion. And then that pregnancy test will be performed 9 days following the transfer. Typically speaking, treatment options and associated success rates can be seen here, and the average individual being 35 years old. For using IUI or timed intercourse cycles has roughly a 10 to 15% success rate per month. IVF has roughly a 40 to 50% success rate, and IVF using genetically normal or PGT tested embryos has a little bit of a higher success rate of 50 to 65%. These success rates will fall as the individual ages, as embryos are then become, the aneuploidy rate goes up, and the genetic abnormalities associated with embryos goes higher. Having more cycles of IVF typically leads to a higher success rate overall. This slide honestly is the most important slide to me. It's not clear. Everyone becomes a parent in a different way. Some people do it naturally and have no issues. Others struggle, and finally make it. It's hard to determine how that process will go for you, but my goal and the goal in Kindbody is typically just to make that whole journey the most comfortable journey possible, and to ensure that you're provided with support, whether that be from your physician, your staff members, the front desk individuals, or even the mental support and counseling support that we have available through our 360 team. Whatever the way that you need your support, we hope to be able to provide that to you. We also have surrogacy options that are available for those who may not be able to use their own egg or sperm or uterus. And so options of all kinds are available. I always tell patients we can get you pregnant. It just depends on how. Selecting an egg donor, we have teams that are ready and available to help you navigate the process of using a donor sperm, using a donor egg, selecting your donor, figuring out what testing needs to be done if you're using a known donor. And so we can go through that entire process with you step by step, so that you feel comfortable navigating the process and know that you're not on your own. Same goes for a gestational carrier, whether you use yourself, whether you use a surrogate or someone who you know, unknown or known. We do our best to ensure that the process is one whereby we're ensuring your safety as well as the safety of your future child. At the end of the day, there are many ways to get to the end goal. And so it's very important to feel that you're supported in this process and feel that you have the best treatment plan that is best for you. And so we hope to provide that for you. So whether you're actually looking to conceive or just trying to preserve your future fertility, or even just know where you're at when it comes to your ovarian reserve status, we are here for you. These are the locations that our current Kindbody clinics are available, and they're ever expanding. We are opening up our Miami and a Dallas location soon, and so that's to come. But Houston is up and running, and so we're excited to work with you all. Thank you so much for coming. We've have this promo code that's going on for those interested in trying to get into care as soon as possible. We are offering 20% off either egg freezing or your IVF treatment. And so if you are planning on undergoing the process of egg freezing or IVF at Kindbody, please make sure that the promo code is used. I'm happy to answer any questions. I know we have a few minutes available. Andrea, if you want to.
Yes, thank you, Dr. Parikh. We actually do have some questions here that were submitted in the chat. First one is, can you experience premature ovarian failure with a regular menstrual cycle?
Generally speaking, even with a regular menstrual cycle, the number of eggs that you start off with, if they're on the lower end, you could still have regular ovulation and regular cycles, but have a lower egg count available. And so, yes, in short, the answer is yes, you can still have regular cycles and be having premature ovarian failure, but typically speaking, as the severity of your POI increases, then it'll kind of be, I usually liken it to a car that's kind of running out of gas. It'll spurt. So there'll be points at which it sort of gets the gas to get moving, and then it'll kind of sort of fall again. And so that waxing and waning is what we try to optimize so that we get the eggs preserved in a wax point as opposed, and avoid the wane points by doing ultrasounds and blood works to see where your levels are at.
Awesome. And another question we have here is, how long does PGT testing take?
The actual process of performing the biopsy itself is done on days 5, 6, or 7. Those biopsies are then frozen. We will then send off those embryo biopsies to be tested for. Once they've been received, it can take anywhere between 5 to 7 days to actually have those results come back to us, and that's 5 to 7 business days, so weekends don't quite count. And so generally speaking, we will have an appointment with our patients as providers roughly about 2 weeks following the retrieval, just to give leeway for the biopsies being sent out and actually being received and getting those results back to us. As soon as the biopsy results are out, we have a whole team of individuals who are ready to release those results to you even before your provider and you actually meet.
Thank you. And I don't see any more questions in the chat, but if anyone has any more questions for Dr. Parikh to answer, feel free to drop them in now. Oh, another question I see here. Is there a sperm bank that you can refer the patient to for same-sex couples?
I do. There are actually 4 or 5 sperm banks that Kindbody routinely, points patients into the direction towards. However, just because it's not listed does not mean that we don't work with them. The typical ones that we work with are Fairfax Cryobank, as well as California Cryobank. Zytex is a company located out in Atlanta, and we have Seattle Reproductive Sperm Bank that's out there. And so these are the top banks that we typically work with. That being said, again, if you have a bank that you've looked at and an individual you're looking to hopefully use, then we're happy to work with you, just ensuring that that bank is a good quality bank, and we would do that for you. Sperm does need to be cleared by the provider prior to use, so please don't purchase your sperm before we've cleared it for you.
Thank you, Dr. Parikh. That's a great reminder. And that's all of the questions that we've gotten. So thank you all for joining us tonight. Be on the lookout for an email we're going to send you tomorrow with more details regarding the promo we have going on. And at the end of this webinar, you'll have a survey. Please fill out that survey if you're interested in starting treatment, so we can have one of our team members contact you. And if you have any other questions, you can reach out to us at any time at navigator@kindbody.com, or you can DM us on Instagram at Kindbody. You can also visit our website, kindbody.com, to schedule a consultation. Thank you all for joining us.
Thank you.
Have a good night, everyone.